Welcome all of you. My name is Prathamesh, and today I'm going to do a small presentation on WHO classification of ovarian tumors. We will discuss its clinical and pathological synthesis, and this content has been taken from the Robbins pathology basis of disease and also practically from the Harsh Mohan practical pathology. So let's dive into it. So before starting anything, we should first know the foundations. So, uh, how the normal ovary looks like. Here we are going to be discussing. So, the ovary consisting of a surface epithelium, which is a single layer of modified mesothelium, which is of cuboidal. It covers the ovary and repairs the post-ovulation. That is, it is broken down during the ovulation and it repairs itself after the post-ovulation. Next, it has cortex, which consisting of germ cells. It contains ovarian follicles in various stages of maturation. It is responsible for oogenesis. Next, inside it has a medulla, which contains sex cords and stroma. It is fibrovascular stroma and sex cords. It drives steroidogenesis, that is estrogen, progesterone and androgen. So here we have a core paradox, that is why are ovarian tumors so heterogeneous. The reason is the ovary is embryologically multipotent. It contains epithelium, germ cell and sex cord stromal elements capable of differentiating into virtually any type of tissue. That's why it is called as heterogeneous. That is, the ovarian tumors are called as heterogeneous tumors. Next, we have the epidemiological landscape. That is where we see the most common of ovarian tumors. Left side we have a graph. In the x-axis we have age in years, and in the y-axis we have incidence of the ovarian tumors. So the incidence is, it is the sixth most common female cancer globally. It is 80% benign, that is in the year 20 to 45 years of age, and nearly 20% malignant. It is at the peak of 40 to 65 years of age. And talking about mortality, highest mortality among the gynecologic cancers due to the late stage presentation. That is, it is known as the silent killer. We have another core paradox. Actually, it is the same. That is why are ovarian tumors so heterogeneous, and you already know the reason. So let us discuss about the pathogenesis and the molecular genetics of the ovarian tumor. First, we have a normal tissue. It has the two pathways, that is the type 1 pathway and the type 2 pathway, which leads to the molecular genetics and which follows the pathology to form the ovarian tumors. The type 1 pathway, it is the stepwise progressions, and the type 2 pathway is the de novo. In type 1 pathway, we have mutations like KRAS, BRAF, P10 and ERBB2. In the type 2 pathway, that is de novo, we have mutations like TP53, which is more than 95%, and also we have mutation of BRCA1 or 2. In the type 1 pathway, that is stepwise progression, it leads to the low-grade tumors, that is the low-grade serous, mucinous and endometrioid carcinomas. These are usually the slow-growing one. In the type 2 pathway, we have high-grade tumors. Those are high-grade serous carcinoma. These are highly aggressive and have chromosomal instability. We have these two lines from the Robbins. We call it as Robbins curve. So, many tumors traditionally were classified as ovarian high-grade serous carcinomas actually originate from the fimbriated end of fallopian tube as serous tubal intraepithelial carcinoma, that is STIC lesions. That one we have to keep in mind. Next we have the WHO classification of ovarian tumors. The WHO classification of ovarian tumors classifies as the first one is the surface epithelial stromal tumors, germ cell tumors, sex cord stromal tumors, and metastatic tumors. The first one, that is the stromal tumors, are 65 to 70% of all the tumors. These are derived from the coelomic epithelium. Next we have the germ cell tumors. These account for 15 to 20% of all tumors. These are derived from totipotent germ cells. The third one, here we have the sex cord stromal tumors, account for the 5 to 10% of all the tumors, and these are derived from ovarian stroma. Metastatic tumors, these account for 5% of tumors. These are basically non-ovarian primaries. Example are GI and breast. You can only understand this classification if you have the good foundation of the ovary, what we have discussed in the second page of the slide. So let us talk about the ovarian tumors one by one. The first one we have here is surface epithelial tumors, that is serous one. So it progresses as benign, borderline, and malignant. The benign is called as cyst adenoma, the borderline is of atypical proliferative, and the malignant is of cyst adenocarcinoma. We have the gross pathology and microscopic morphology of the serous surface epithelial tumors. As in the gross pathology, we can find it is often bilateral. It is unilocular or multilocular cysts filled with clear serous fluid, distinct papillary excrescence on the surfaces. And about microscopic morphology, microscopy, cuboidal to tall columnar ciliated epithelium. And one of the hallmark feature which we can use microscopically to know whether it is a serous surface epithelial tumor is we can find the psammoma bodies. These are concentric calcifications which are found in the papillae. And about clinical data, clinical profile, we have it as it constitutes 25% of all the ovarian tumors. It has a strong association with BRCA1, 2 and TP53 in high grade variants. Its serum marker is CA125, which is elevated. So next we have surface epithelial tumors, that is mucinous. Its gross pathology. It is huge multilocular cysts. It can weigh greater than 25 kg. It is filled with thick, sticky, gelatinous mucin. It is rarely bilateral, unlike serous tumors, which are basically bilateral one. So this is one of the differentiating feature from the serous and mucinous surface epithelial tumors. Next we have the microscopic morphology. In the microscopy of mucinous surface epithelial tumors, we have these are lined by tall columnar non-ciliated cells. Abundant apical mucin vacuoles resembling endocervical or intestinal epithelium. Clinical data, we have KRAS, that is cross mutations are very common in mucinous surface epithelial tumors. Its complication is pseudomyxoma peritoniae, that is jelly belly, extensive mucinous ascites. It is often secondary to an appendiceal primary rather than ovarian. So this is about the mucinous surface epithelial tumors. Next one we have endometrioid and clear cell tumors. So it's better to know these tumors in a tabular column so we can get a question of it on it. There is endometrioid carcinoma and clear cell carcinoma. We'll discuss about gross, microscopy and clinically genetics related. So gross of endometrioid carcinoma we have, it is a solid and cystic with frequent areas of hemorrhage. And in clear cell carcinoma, the gross is, it is a solid or cystic intimately associated with endometriosis. Microscopy of endometrioid carcinoma, tubular glands resembling normal or malignant endometrial glands. And microscopy of clear cell carcinoma is, it is solid sheet of clear glycogen rich cells. One of the hallmark of differentiating feature of endometrioid carcinoma and clear cell carcinoma is, in clear cell carcinoma we have hobnail cell, that is nuclei protruding directly into the cystic lumen, and we also have a small illustration of it. Endometrioid carcinoma, that is genetics and clinical, it is associated with P10 mutations, and concurrent endometrial carcinoma arises in the setting of endometriosis. In the clear cell carcinoma, ARID1A mutations are common. It is highly aggressive with a poor prognosis. What does it mean? It means that endometrial carcinoma has a good prognosis and clear cell carcinoma has a poor prognosis. So next one we have Brenner tumors and mixed epithelial tumors. Morphology pole, that is, it has a coffee bean nuclei. That is, the nuclei exhibit characteristic longitudinal grooves. It's gross and clinical, that is, it is a solid, firm, well circumscribed mass, pale yellow-white appearance on cut section. It is usually benign. Microscopic architecture, nests of transitional, that is urothelial-like epithelium surrounded by a dense fibromatous stroma. We have a memory trick to remember this, that is Brenner. That is the bladder-like epithelium, which is usually a benign one. So Brenner tumors and mixed epithelial tumors are basically the benign tumors. And the morphologically and microscopically, these are exhibits the coffee bean nuclei, as you can clearly see in the illustration. Next we have epithelial tumors, that is, we have a proper tabular column with whatever it is important. So we have tumor type, its epithelial resemblance, whether it is bilaterality, it is histology, and its genetics. First we will talk about serous. Its epithelial resemblance is fallopian tube. It's 20% benign and 65% malignant. Its histology is, it is ciliated, some homobodies are hallmark. Genetics, BRCA and TP53 mutations. Mucinous. Epithelial resemblance, cervix and intestine. Bilaterality less than 5%. Key histology is apical mucin vacuoles are found. Genetics is cross gene or mutation. Endometrioid, epithelial resemblance is endometria. Bilaterality is 30%. Histology is tubular glands can be found. And genetics is P10 mutations. Clear cell. Epithelial resemblance is gestational endometrium. Bilaterality is 40%. Key histology is hobnail cells and glycogen. Genetics is ARID1A gene mutation. And at last we have Brenner. Epithelial resemblance is urothelium, that is the bladder. Bilateral is rare. Key histology as already discussed. We have already discussed, that is coffee bean nuclei, and genetics is basically a rare. Next we have, so these are all the epithelial tumors what we have discussed till now. Next we will move to the germ cell tumors, also called as teratomas. These are derived from totipotent germ cells capable of forming all the three embryonic layers, that is ectoderm, mesoderm, endoderm. These are the three embryonic layers. So first one we have mature cystic teratoma, that is called as dermoid cyst, and immature teratoma. First we will discuss about mature cystic teratoma. It is basically a benign tumor. It's gross, it's unilocular cyst containing bizarre elements like hair, cheesy sebum, teeth, and bone. Microscopy. Mature, fully differentiated tissues from all the three germ layers, that is ectoderm, mesoderm, endoderm. Example, that is skin, cartilage, and respiratory epithelium are example for the three types of embryonic layers. ectoderm, mesoderm, endoderm respectively. Next one we have immature teratoma. It is basically malignant and it is a fast growing one. Microscopy contains immature or embryonal tissues. So we have a grading that is strictly based on the amount of primitive neuroepithelium present. We grade the immature teratomas. We have a specialized complication in the germ cell tumors, that is struma ovary. A monodermal teratoma composed of entirely of mature thyroid tissue presents clinically with hyperthyroidism. So we can have a differential diagnosis here. Next we have dysgerminoma and yolk sac tumor. Yolk sac tumor is also called as endodermal sinus tumor. First we will discuss over dysgerminoma. It is ovarian equivalent of testicular seminoma. Microscopy: nests of large clear cells with prominent central nuclei, that is fried egg appearance. Fibrous septa are infiltrated by lymphocytes. Serum markers are elevated LDH, lactate dehydrogenase, and sometimes HCG, human chorionic gonadotropin. Clinically, we have highly radiosensitive with excellent prognosis. Yolk sac tumor. It is highly aggressive than dysgerminoma. Microscopically, it has reticular network structure. Hallmark is Schiller dual bodies, primitive glomerulus-like structures. Markers serum. Serum markers we have markedly elevated AFP, that is alpha fetoprotein. This is about dysgerminoma and yolk sac tumor. Next we have embryonal carcinoma and choriocarcinoma. Embryonal carcinoma. It is highly aggressive proliferation of primitive large embryonal cells. Demographic, that is typically presents in adolescents and young adults. Behavior. It features rapid early metastasis. Serum markers are both HCG and AFP are often elevated. We have ovarian choriocarcinoma. Microscopically, malignant proliferation of cytotropoblasts and syncytotropoblasts. Crucial distinction is no chorionic villi found. Clinically, markedly elevated beta HCG levels can cause precocious puberty or irregular bleeding. Its behavior: it is extremely vascular, spreads early via blood to the lungs, liver and brain, unresponsive to routine chemotherapy, unlike placental choriocarcinoma. Next we have sex-cord stromal tumors, that is granulosa and thecoma. It is better to discuss differentiating features. Granulosa cell tumor and thecoma. Endocrine effect of granulosa cell tumor: it produces massive amounts of estrogen. Clinical presentation: precocious puberty in children, endometrial hyperplasia and postmenopausal bleeding in older adults. Microscopically, small cuboidal cells in sheets or cords. Hallmark is Karl-Exner bodies, gland-like rosette structures of cell arranged randomly around eosinophilic fluid. Tumor markers are elevated serum inhibin. Let's discuss about thecoma. Its behavior: it is a benign one. Gross, solid, distinctively yellow tumor, microscopically composed of plump cells, composed of plump spindle cells loaded with clear lipid droplets. Endocrine effect: it also produces estrogen, driving similar clinical symptoms as granulosa cell tumors. Next we have fibroma and sertoli-Leydig cell tumors. Fibroma: it is a benign, hard, chalky white solid mass composed of spindle cells, fibroblasts and abundant collagen. No hormone production. It resolves entirely upon tumor resection. We have Meigs syndrome triad, that is, it consisting of ovarian fibroma, ascites and right pleural effusion in the fibroma. Next we have sertoli-Leydig cell tumor. Endocrine effect: it produces androgens. Clinical presentation: defeminization followed by virilization, that is hirsutism, deepening of voice, clitoromegaly, amenorrhea in young women. Microscopically, tubules lined by Sertoli cells. Stroma contains Leydig cells bearing characteristic rinky crystalloids. Next we have metastatic tumor, that is Krukenberg tumor. The Krukenberg tumor: it is a specific type of metastatic ovarian cancer characterized by bilateral solid masses. Its primary origin: it most commonly arises from the gastric adenocarcinoma. It is of diffuse type. It can also metastasize from colon or breast primaries. It is a secondary tumor of breast cancer. Basically, it is a speaking of. Microscopic hallmark, mucin producing signet cells, ring cells, proliferating within a highly cellular ovarian stroma. We have a clinical rule for the differential diagnosis. If bilateral solid ovarian masses are found, aggressively investigate the GI tract to rule out the primary malignancy before assuming an ovarian origin. So we have a master WHO synthesis matrix in this tabular column. So we have category, tumor type, cell of origin, hormone, tumor marker. So epithelial, serous, cell of origin surface, hormone, none, tumor marker CA125. So category of epithelium, tumor type mucinous, cell of origin is surface, epithelium, hormone is none, tumor marker are CA125 and CEA. So we have germ cell tumors, that is dysgerminoma, cell of origin oocyte, hormone none, tumor markers is LDH and SCG. Tumor type yolk sac, germ cell is a cell of origin, hormone is none and tumor marker is AFP. Choriocarcinoma of tumor type, cell of origin again germ cell, hormone none, tumor marker is beta SCG. Now we have sex cord tumors, that is granulosa cell and sertoli-lytic. Granulosa cell of origin is a follicle and sertoli cell lytic cell of origin is stroma. Hormone in sex cord, that is granulosa cell, is estrogen, and sertoli-lytic we have androgens. Tumor marker of granulosa cell is inhibin and sertoli-lytic is of none. Next we have metastatic, tumor type is Krukenberg, cell of origin may be gastric or GI, hormone is none, tumor marker is CEA. So we have clinical features and acute complications. We have torsion, that is of these are complication and clinical features of ovarian tumors. That is the first one. We'll discuss about vague symptoms, that is bloating, early satiety, dyspepsia. Next we have pelvic pain, pressure, palpable solid cystic mass. Next we have ascites, especially with epithelial malignancies and fibromas. Next we have signs, that is torsion, twisting of ovarian pedicle, cuts off arterial venous supply. Extremely common in heavy mobile tumors like mature cystic teratomas and fibromas. Presents as acute surgical abdomen. Next, rupture, spontaneous or traumatic bursting of cysts, causes severe chemical peritonitis, especially mucinous or teratoma contents, and internal hemorrhage. Infertility and hormonal dysfunction, bilateral destruction of normal ovarian parenchyma, endocrine tumors disrupt normal menstrual cycles, precocious puberty, amenorrhea, postmenopausal bleeding. So these are clinical features and acute complications of ovarian tumors. So diagnostic pathway. Let us discuss about diagnostic pathway of ovarian tumors. First, clinical assessment, that is bimanual examination by the doctor, identification of palpable pelvic mass, ascites or hormonal signs. Next, pelvic ultrasound. It is a first line diagnostic pathway, crucial for differentiating solid versus cystic structures. Assess for septations, that is papillations and vascularity. Next, CT or MRI imaging, essential for staging of ovarian tumors. Evaluates lymph nodes, liver, parenchyma and peritoneal implants. Serum tumor markers, blood panel, we have CA125, AFP, alpha fetoprotein, SCG inhibin to estimate tumor origin and establish a baseline for post-op monitoring. Next we have surgical pathology, it is a gold standard one. Definitive diagnosis requires tissue. Intraoperative frozen section dictates the immediate extent of surgery. So staging, that is called as FIGO classification. Stage 1, if the tumor is strictly confined to one or both ovaries, high survival rate if caught here. Stage 2, tumor extends into the pelvic region, uterus, fallopian tubes or other pelvic tissues. Next we have stage 3. Tumor involves macroscopic or microscopic peritoneal implants outside the pelvis or positive retroperitoneal lymph node. Next we have most common presentation, that is stage 3. Next we have stage 4. Distant metastasis beyond the peritoneal cavity, involves liver, parenchyma or pleural fluid. Clinical significance, prognosis drops precipitously between stage 1 and stage 3, emphasizing why ovarian cancers are silent early. Growth is so lethal. So how do we manage it? Management principle: surgical cytoreduction, that is staging, laparotomy, and aggressive debulking. The surgical goal is less than 1 centimeter of residual macroscopic disease. Targeted therapy: modern revolution, VARP inhibitors, example olaparib, used specifically for BRCA mutated serous carcinomas by exploiting synthetic lethality in DNA repair. At last, we have chemotherapy, that is standard systemic therapy post surgery, platinum based regimens, example carboplatin and paclitaxel. These are comprehensive follow up. Serial monitoring with clinical exams, imaging, and tumor markers like HE4, CA125 to detect early relapse. So, this was all about the WHO classification of ovarian tumors. We have discussed everything from the foundation till diagnostic pathway and management principle. We have also learned about the WHO classification of ovarian tumors in a tabular way. We have also learned about the differentiating features of all these tumors. So this was it. Thank you.